All these midnight lectures are just gonna push you to the one step closer to USMLE dream, and this is why we study for. This is why we grind for. So buckle up and welcome back to Not So Complicated. This is session 2 of our gastrointestinal pathology. We have completed a lot of portions yesterday, and grab a cup of coffee. Let's begin our inflammatory bowel disease without any further delay. So what are inflammatory bowel disease? Inflammatory bowel disease, there are two types of inflammatory bowel disease. Actually, they are in cases like it has a multi-pathological, it has multi-etiologenesis. That is, one of them is autoimmune diseases, and also like they are autoimmune, can be autoimmune diseases, and also gut flora, gut flora disorientation can also occur this. So there are many differences between this Crohn disease and then ulcerative colitis. We have to remember this too, because this is a very high yield topic, and you let's stay, you have to stay, don't skip please. Yeah, so let's begin, right? So where does the Crohn's disease actually occurs? The location is that any portion of the GI tract. It can occur in any portion of the GI tract, usually terminal ileum and colon. And then the difference is that it is a colitis, ulcerative colitis, right? So it is exclusively in colon inflammations, continuous colonic lesions, but there it can occur in ileum, right? So this has characteristic escape lesions and also rectal sparing. The rectum is not affected in Crohn's disease, not in usual cases, but it can get affected, right? So in gross morphology, the Crohn's disease shows transmural inflammation, and that will lead to fistulas. That is abnormal connection between two different parts, right? That is fistula. And the high yield thing that you have to remember here is cobblestone mucosa, creeping fat, bowel wall thickening. Not bowel wall thickening, you don't have to remember this, but this creeping fat and cobblestone mucosa is a very high yield, and string sign and small bowel follow through is seen. Lineal ulcers and fissures. If fistula gets severe, that can lead to fissures, right? So let's see in the figure here, there is bowel wall thickening, obviously these arrows here, and this here is cobblestone appearance, right? So actually in ulcerative colitis, it is mucosal and submucosal inflammation only, not transmural. Transmural is that the muscle layer of the mucosa or muscle layer of the the membrane, right? The mucosal membrane is affected, but not only the mucosal and submucosal inflammation. So actually it occurs in ulcerative colitis, and there are friable mucosa with superficial and slash or deep ulcerations. Compare normal B with diseased C. Let's compare here. This is very normal case, right? So this is the diseased case in the case of ulcerative colitis. You can see the lesions, right? It's explained lesions right here. Friable mucosa, which is friable is breakable, easily breakable, brittle mucosa is there with superficial or deep ulcerations, right? And then loss of ostra will cause lead pipe, right? These are the hostrations of large intestine. This is how large intestines are made, with hostrations or pockets like integrity, right? So loss of hostration will lead to lead pipe appearance. So what are the two different things? String sign is seen in Crohn's disease, and lead pipe appearance is in ulcerative colitis, right? So in microscopic morphology, there is non-causating granulomas and lymphoid aggregates in Crohn's disease, and crypt abscesses and ulcers are present in ulcerative colitis, and also bleeding with no granulomas can occur, right? So in complications, what we talk about complications is that malabsorption or malnutrition are complication. Colorectal cancer that will that increase with risk with pancolitis. Pancolitis, all the portion of colon is affected, right? So these are the complications. Fistulas can occur in Crohn's disease as in intravesical fistula, which can cause what is it? Recurrent UTIs. Intravesical means there is an abnormal connection between urinary bladder and then intestine. That can cause obviously recurrent UTI due to gut flora like E. coli and also pneumonia. Phlegmon or abscess, strictures causing obstruction, perianal disease. These are the cases, right? These are the complications. And fulminant colitis, that is end stage colitis level, it is almost irreversible in this case. And toxic megacolon, that is enlargement of enlargement of colon region due to accumulation of feces that causes toxic megacolon, and also perforation can occur due to overdistension by the feces, right? So that can occur in ulcerative colitis. And in intestinal manifestation, there is diarrhea that may or may not be bloody, but in ulcerative colitis it is bloody diarrhea and it is usually painful. You have to remember this. And extraintestinal manifestation, the common symptoms that can occur in both of these diseases is that rashes, that is pyoderma gangrenosum, erythema nodosum, eye inflammation like episcleritis, uveitis, oral ulcerations like aphthous stomatitis. Stomatitis is actually occurs in the corner of our lips, right? So arthritis also peripheral, can be peripheral arthritis or spondylitis too. So the specific extraintestinal manifestations in both of them is that in Crohn's disease there can cause calcium oxalate kidney stones, that is due to inflamed intestines, and that inflamed intestines will lead to malabsorption of fat, right? That fat binds to calcium in the intestine, and excess free oxalate in the intestine is present. That will increase the reabsorption of oxalate, and that oxalate combines with calcium in kidneys, forming kidney stones or renal calculate. This is the pathophysiology of calcium oxalate kidney stones, right? So there is malabsorption of fat, and fat binds with calcium in intestine, and that will lead to excess of free oxalate in intestines, right? So that will lead to increase in oxalate reabsorption, and those reabsorbed oxalate will bind to calcium in kidneys, causing renal calculi and also gallstones. It may be positive for anti-Saccharomyces cerevisiae antibodies. Saccharomyces cerevisiae is yeast, and it is yeast infection. And in colitis, ulcerative colitis, there is primary sclerosing cholangitis that can occur due to associated with MBO, ANCA or PANCA gene or autoimmune antibodies, right? So you have to remember that the treatment of Crohn's disease is that glucocorticoids, azathioprine, and also antibiotics, example ciprofloxacin, metronidazole. Ciprofloxacin belongs to the fluoroquinolones group, so we will study that in our pharmacology session, most probably after finishing our pathology. And then biologics, example infliximab and adalimumab can be used. And in ulcerative colitis, there are 5 aminosalicylic acid preparations like mesalamine and sulfasalamine that can occur, and also 6-merceptopurine can be used in infliximab, and colectomy can be done. Colectomy is the removal of the portion of colon which is getting affected, right? So, and also disease activity, there is fecal calprotectin used to monitor activity and distinguish from non-inflammatory diseases, that is irritable bowel. Irritable bowel is a non-inflammatory disease. So we have completed our inflammatory bowel disease by these differences, and then we will do the clinical case discussion in upcoming days. So you can subscribe the channel for these clinical case discussions, where we have already made of almost 10 or 13 to 14 clinical cases too. So you can get connected with our community, where we will freaking crash the USMLE by getting to 60 plus. That is our target. So microscopic colitis is that inflammatory disease of colon that causes chronic watery diarrhea. This is chronic watery diarrhea, right? So it is most commonly found in older females, and colonic mucosa appears normal on endoscopy. And then endoscopic tube is actually inserted inside our intestine from esophagus, from mouth, on the basis of some markings of esophagus. There are different sphincters, different portions that in esophagus can affect, right? So we'll talk about that in our anatomy clinical section. And also histology shows lymphocytic infiltrate in lamina propria with intraepithelial lymphocytosis or thickened subepithelial collagen band. That is what it is. So in irritable bowel syndrome, what actually happens is that there is recurrent abdominal pain, which is associated with at least 2 of these following criteria. And 2 of these following criteria is related to defecation and change in stool frequency, change in form or consistency of stool. That occurs in irritable bowel syndrome. Recurrent abdominal pain associated with greater than 2 of them following. That is It can either be due to related to defecation, or it can be related to change in stool frequency or change in form or consistency of a stool. It can be hard stool or soft stool, right? So there are no structural abnormalities in irritable bowel syndrome, and the most common is found in middle-aged females. Middle-aged females. This is the highest frequency, and chronic symptoms may be diarrhea predominant or constipation predominant or mixed. This means that this disease can either be manifested as diarrhea predominant in the change in form or consistency. It can be diarrhea, or can be constipation, or can be mixed, right? So pathophysiology is multifaceted. It may be associated with fibromyalgia and mood disorders like anxiety and depression. And first line treatment is lifestyle modification and dietary changes. We do not use any antibiotics because this is not a case of inflammation, right? So another thing we will talk is appendicitis. This is very, very important thing, and it is most excessively asked in USMLE too. And then it is the acute inflammation of appendicitis. You can see in here. I'll tell you, this portion here is appendicitis. Right here, there is the dilatation of appendix, vermiform appendix. The vermiform appendix actually lies in the cecum, right? We all know that. And there is dilatation. You can see this portion here. This is a colon, right? This is ascending colon. This is transverse colon, descending colon. This is sigmoid colon, and this is rectum, and this is anal portion right here. That is what it is. So in cecum there is appendicitis. Sorry, there is vermiform appendix, and that portion is getting inflamed in here. It can be due to obstruction of fecalith. Fecalith is actually the stone in the small stone that is made up of calcium or oxalate or just fatty set crystals, right? So that can occur in adults, or due to lymphoid hyperplasia in the case of children. So proximal appendiceal lumen obstruction occurs. For example, this is vermiform appendix, and this is the lumen of appendix, right? So it can happen when there is obstruction. For example, this is the obstruction, right? So this is proximal appendiceal lumen obstruction that will lead to closed loop obstruction, and that will lead to increase in intraluminal pressure. The secretion occurs from the wall of these portions, right? It cannot get drainage out, so this will lead to a it will lead to the dilatation, and also intraluminal pressure will increase, so it can lead to stimulation of visceral efferent nerve, as T8 to T10, and initial diffuse periumbilical pain. This is the reason why periumbilical pain is present in the case of appendicitis in the earlier region, right? So this is the case of dermatom, right? Dermatom is the region, T8 to T10. And also the inflammation extends to serosa and then irritates parietal peritoneum. Pain localized in right lower quadrant, or more specifically this is McBurney's point. McBurney's point, how do you calculate McBurney's point? This point actually is, for example, this is umbilicus, right? For example, this is umbilicus, and there is ischial, this is pelvis, and this is ischial region, right? So this is the space in here. This is vertical line between those regions, right? So it is 1/3 distance from the right anterior superior iliac spine, 1/3 region from right anterior, this 1/3, for example, this, and 2/3 from the umbilicus. This point right here is McBurney's point, and there is tenderness in this point in appendicitis. Nausea, fever may be there, and it may perforate. That will lead to the complication, that is peritonitis, because since this is the portion in the intestine, and there is a lot of peritoneum covering these intestinal organs, right? So visceral organs. So if the perforation occurs in here, the accumulation of this bacteria will spread to all of the other regions. That will lead to peritonitis, and it may elicit SOAS obturator, and also Robsing's test can be done, right? SOAS sign, Robsing signs, obturator signs are for different location, different form of location in the appendicitis, because appendicitis usually like it can be retrocecal, ileocecal. We will talk about this in our clockwise classification of appendicitis, appendix in anatomical portion. And guarding and rebound tenderness on exam is present. The treatment is appendectomy. It can either be open appendectomy or a laparoscopic appendectomy, which is a very common procedure in recent days. So diverticula of the GI tract. Let's talk about diverticula. What is diverticula? Okay, basically diverticula, it can be diverticulum, it can develop into diverticulum, and diverticulosis and diverticulitis. We'll talk about all three of these. And also there is something called Zenker diverticulum. We'll talk about that too. Meckel's diverticulum, Hirschsprung disease. This is another syndrome which is very high yield for USMLE. So in diverticulum, this is a blind patch. You can see in figure. This is a blind patch. You can see, right? So what actually it is a protruding from the alimentary canal or alimentary tract that communicates to the lumen of the gut. Alimentary canal communicates to the lumen of the gut. The most diverticula are present in esophagus, stomach, duodenum, colon, are acquired and also termed as false diverticula. Right? What is diverticula? It is simply blind patch. And true diverticulum is that all gut wall layers are outpatching. That is true diverticulum. But if only one part like mucosa or submucosa is outpatching, that is called false diverticulum or pseudo diverticulum. You have to remember this. And then it occurs especially where vasa recta penetrate muscularis external here, that is in Zenker diverticulum. So what is diverticulosis? That is many false diverticula of the colon is diverticulosis. You can see in here, these are very much diverticula, many false diverticulas because there is no outpatching of all gut wall layers. There are 4 layers in the gut wall, right? So serosa, then mucosa, submucosa, and intima kind of thing. There are 4 layers. You have to remember this, and it is commonly sigmoid. So the common in 50% of people greater than 60 years, it is caused by intraluminal pressure rise and also focal weakness in the colonic wall. That will lead to the outpatching, right? For example, this is our intestinal alimentary canal, and these walls get weak. Now this lead to the blind patch like this, right? This is just like aneurysm but in gut. Aneurysm of gastrointestinal system is diverticulosis, to remember that. So also it is associated with obesity and diets low in fiber, high in total fat or red meat, and often these are asymptomatic or associated with vague discomfort, and complications include diverticular bleeding, painless hematochezia. So there is difference between hematochezia and melena, right? Melena is the blood present in feces, but that is present in digested blood. Hematochezia is fresh blood, so it is reddish in color. It is brownish, coffee brown color in our melena, but in hematochezia it is red, bright red color in stool. And also diverticulitis can occur. So what is diverticulitis? This is the inflammation of diverticula with wall thickening, right? This is inflammation. Everything that has itis in its last is inflammation. You can know that already. It is classically causing left lower quadrant pain, fever, and leukocytosis. In this case, here you can see these arrows. These are our diverticulas, right? So treat with supportive care in uncomplicated cases and antibiotics in complicated cases. What are the complications in diverticulitis? It can cause abscess. How abscess occurs? Like something collects, like pus or something is collect, and that is getting infected. That will lead to abscess. And also fistula, colovesical fistula is there. Also colovesical means the abnormal connection between colon and urinary bladder. That will lead to pneumaturia, right? Pneumaturia is that there are air bubbles passing in urine, right? That is very painful. Air bubbles are passing, and obstruction, that is inflammatory stenosis, can occur. And in perforation, white arrows you can see, these are the signs of perforations that will lead to peritonitis. Hematochezia is rare in diverticulitis. So hematochezia is the problem of diverticulosis, not diverticulitis, right? So let's talk about Zenker diverticulum. Here you can see this is Zenker diverticulum. There is specific feature in Zenker diverticulum, which is this, that pharyngoesophageal false diverticulum is present. Pharyngoesophageal. It can occur either in pharynx or in esophagus or in the junction of pharynx and esophagus. So esophageal dysmotility causes herniation of mucosal tissue at an area of weakness between the thyropharyngeal and cricopharyngeal parts of the inferior pharyngeal constrictor, that is Killian triangle. In Killian triangle, it occurs in Killian triangle, right? This is Zenker diverticulum. There is thyropharyngeus muscle, and also there is cricopharyngeus muscle. These muscles are the muscles of pharynx, right? These muscles are very supporting muscles of pharynx, and they change in opposite direction. These two muscles change in opposite direction during deglutition and reglutition, and that forms a part called Cillian triangle in here. This is very common, right? Cillian triangle is present in every human individual, and if the pressure is arising, right, if this muscle constantly contracts and this doesn't relax, and this also contracts, usually what happens that this is contracting, this is relaxing, this is contracting, this is relaxing. But if both of these contracts simultaneously, then the outpouching can occur in here at Zenker diverticulum, in pharyngoesophageal false diverticulum, it's Zenker diverticulum. The presenting symptoms are dysphagia, difficulty in breathing, obstruction, gurgling, aspiration, and foul breath and neck mass can be present. It is most common in older males, right? That is how we remember. And Meckel diverticulum, it is a true diverticulum. So Zenker diverticulum is a false diverticulum. This is very high yield, you have to remember. And Meckel diverticulum is a true diverticulum. This is also high yield, you have to remember. Meckel diverticulum usually occurs in younger children, like just infant kind of children. So there are reasons for Meckel's diverticulum. There is a very specific rule of twos, you can see in here. So rule of twos is that 2 times is likely in males, 2 inches long, this is 2 inches long, and it is 2 feet from the ileocecal valve. Ileocecal valve is that this is cecum, right? And there is ileum in here, and that has a valve in here, right? So that valve is ileocecal valve, and that ileocecal valve, it is distant, like Meckel diverticulum is distant from 2 feet from ileocecal valve. That can occur, and it occurs in 2% of the population, commonly presents in first 2 years of life, as I have talked earlier. This is present in children, and it may have 2 types of epithelia, that is gastric or pancreatic epithelia. These are the rule of twos. You can remember. It's not you can, it's you must have to remember this, right? So Meckel diverticulum, let's talk about it. It is the persistence of vitelline, that is omphalomesenteric duct, persistence of vitelline duct. Remember this. And may contain ectopic acid secreting gastric mucosa or pancreatic tissue can occur. Most common congenital anomaly of GI tract is Meckel's diverticulum. Remember this. Very high yield. Most common congenital anomaly of GI tract is Meckel's diverticulum. It can cause painless hematogagia or melena in less common cases, right lower quadrant pain, and intussusception. Intussusception is a case of intestinal obstruction. What actually happens is that in peristalsis, the preceding part of intestine will jump into inside the interior of the receding site. That is what it actually happens during peristalsis. And also volvulus can occur. Volvulus is the twisting of intestine, and or obstruction near terminal ileum, right? So diagnosis is done by 99M technetium per technetated scan, which is also called a Meckel scan for uptake by heterotopic gastric mucosa. That is it. Technetium per technetated scan, which is also called Meckel scan. So diagnosis is done like that. There is Hirschsprung disease. This is also congenital megacolon case, or toxic megacolon case. Like you can see in here, there is enlargement of the colonic portion due to distension, right? Why this is happening? Because the feces are accumulating in this and they are not being able to pass. Why? So we will talk about it in here. So congenital megacolon is characterized by the lack of ganglion. Ganglions also enteric nervous systems, plexus is Auerbach's and Meissner's plexus in distal segment of colon. That is the case. there is congenital lack of enteric nervous system. Since there is no nervous system, there is nothing that will guide peristalsis in that case, or constrictions in those regions, right? So there is no peristalsis, there is no movement of stool or feces, so that stools and feces are accumulating in that portion. So this is due to failure of neural crest cell migration, and it is associated with loss of mutations and rate. This is rate mutations, RET, and it presents with bilious emesis. Emesis is vomiting. Bilious is there are bile acids, that is greenish vomit is present, and abdominal distension is there, and failure to pass meconium within 48 hours will lead to chronic constipation. That can even complicate into abstipation. You have to remember this word. Abstipation is that in constipation only feces are not getting passed, right? But in abstipation, the feces along with the fat is not getting passed. Even the gases are not getting passed. So normal portion of the colon proximal to the ganglionic segment is dilated, resulting in transition zone or toxic megacolon. Notes in this case is there is increased risk with Down syndrome, and explosive expulsion of feces, that is squid sign, will lead to empty rectum on digital exam. Explosive expulsion of feces, that is squid sign. Squid sign is explosive expulsion of feces that will lead to empty rectum on digital exam, and it is diagnosed by absence of ganglion cells on rectal suction biopsy. Treatment is rejection. There is no other way, because you cannot regenerate nerves in any people, right? So rate mutation in the rectum, you can remember like that, rate mutation in the rectum. Okay, we complete our Hirschsprung disease like that, and we'll talk about malrotation now, and also intussusception. These are the cases of obstruction, intestinal obstruction, intussusception. Like I have made a figure in here, we'll talk about that, and then volvulus, and also short bowel syndrome. Okay, so malrotation. What is malrotation? Usually in the development of stomach or visceral organs or gastrointestinal regions, what actually happens is rotation happens, like foregut rotation, mid-gut rotation, right? If that rotation is abnormal, then obviously there are manifestations in the our life, right? So anomaly of mid-gut rotation during fetal development will lead to improper positioning of bowel, that is small bowel clumped on the right side and colon on the left side. This can happen, right? Colon can occur in the left side, right? And formation of fibrous bands like lad bands in here. You can see this lad bands. This is very high yield lad bands, and it can lead to volvulus duodenal obstruction. That is malrotation. So what is intussusception? So this word intussusception, telescoping, you can remember like this. This one single word will make you remember what intussusception is. So telescoping of a proximal bowel segment into a distal segment like this, right? Why this is happening? Because the peristalsis of this region is having faster than the receptive region. That is why it occurs most commonly at ileocecal junction, and it is typically seen in infants. It is usually idiopathic in children, less frequently due to an identifiable lead point, and idiopathic form is associated with recent viral infections like adenovirus, rotavirus vaccine that will lead to Peyer's patch hypertrophy may act as the lead point. Peyer's patch. Peyer's patches are usually found in our intestine, right? Small intestine, and also in ileum. That is the reason where Salmonella typhi attacks. We'll talk about that in microbiology sessions. So this is gonna be a very long. We are preparing USMLE. We will tap into every depth of what we can, right? So you better subscribe and get connected with us. And also we are trying to provide 4,000 plus questions and answer booklets in less than $30, which will cost almost $600 in other resources, right? So we are trying to make medical education affordable, so you can support us just by subscribing, right? Thank you in advance, right? So let's go back. In common lead points, intussusception can occur in children, that is mecal diverticulum, small bowel wall hematoma, IgA vasculitis, and in adults as in intraluminal mass or tumor, and that will lead to that will cause small bowel obstruction and vascular compromise, and that will lead to intermittent abdominal pain, vomiting, bloody current jelly stools. This is very high yield, specific current jelly stools in intussusception. You have to remember this, and also sausage shaped mass in right abdomen examination is seen, and patient may draw their legs to chest to ease pain. This is characteristic feature. Relief of pain occurs if the patient draws their legs to chest, right? You can remember like that. And then ultrasound or CT may show target sign. There it is, target sign. It is just like the archery target sign, right? This, remember this, there is target sign in ultrasound or CT in intussusception. And in bulbous cases, what actually happens is there is like obstruction like this. There is twisting of the bowel, twisting of portion of bowel around its mesentery is what valvulus is. It can lead to obstruction and infarction, right? So it can occur throughout the GI tract. Intussusception most frequently occurred in ileocecal junction, right? So it can occur in throughout the GI tract. So gastric valvulus are more common with abnormalities like paraesophageal hernia in adults, and presence with severe pain, dry heaving, and inability to pass nasogastric tube. And also midgut valvulus, more common in infants than children, that is minors. Midgut valvulus are more common in minors. M for midgut, M for minors, that is infants and children. And then sigmoid valvulus, that is coffee bean sign on X-ray. You can see in arrows here. There is coffee bean sign, right? So coffee bean signs in X-rays are seen in sigmoid valvulus cases, this region. It is more common in older adults, that is seniors. As for sigmoid valvulus, as for seniors, M for midgut valvulus, M for minors, like infants and children. So let's talk about short bowel syndrome. What is short bowel syndrome? Short bowel syndrome is the inability to adequately absorb nutrients in small intestine, but not primary. It is secondary to significant surgical rejection. Like for example, there is a marked infarction or gangrenous intestine, right? So we have to cut it off. We reject this entire portion, and this had the usual function of absorbing the nutrients that we have fed to ourselves, right? So if there is no portion to absorb the intestine, so there is decrease in absorption, right? That is short bowel syndrome, and it is secondary to surgical rejection, as in Crohn's disease, malignancy, trauma, and it can lead to malabsorption of bile salts, fat at the distal ileum, which will lead to postprandial voluminous diarrhea, dehydration, and then weight loss, anemia, calcium oxalate, kidney stones that can occur. Okay, so the pathophysiology of calcium oxalate, kidney stones, I have talked about it earlier. And in other intestinal disorders, it can be acute mesenteric ischemia, which is there is no oxygen supply or perfusion in the case of mesentery, right? Mesentery are these are the seats of organs. There is critical blockage of intestinal blood flow, often embolic occlusion of SMA, that will lead to small bowel necrosis, and obviously abdominal pain out of proportion to physical findings. That is, there is little to no physical findings, but pain is extreme, and it may see red current jelly stools again. So current jelly stools are also seen in where? They are seen in intussusception cases, and they can be seen in acute mesenteric ischemia. Risk factors are atrial fibrillation, peripheral arterial disease, PAD, recent MI, CHF, congestive heart failure. These can be the risk factors, right? So that is what it is. There may be a figure in here. You can see this portion right here. This is a case of acute mesenteric ischemia. So angiodysplasia is there. This is the torsosization of vessels that will lead to hematogasia, most often found in right-sided colon, more common in older patients, confirmed by angiography, and associated with end-stage renal disease, ESRD. Von Willebrand disease, this is a disease of coagulation disorder. We had talked about it on hematology, and if you haven't watched the hematology video, you can watch 3 videos of series, and aortic stenosis can occur. And in chronic mesenteric ischemia, this is intestinal angina. You can remember like that. There is atherosclerosis of celiac artery, where there is atherosclerosis of cardiac arteries in the case of angina, myocardial angina. And SMA is most commonly affected, or IMA will also IMA is affected, that will lead to intestinal hypoperfusion, postprandial epigastric pain. Postprandial epigastric pain meaning that there is pain in abdomen after we feed something, that is food aversion and weight loss can occur, right? And in colonic ischemia, what actually happens is there is crampy abdominal pain followed by hematochezia. I have explained what is hematochezia. It commonly occurs at watershed areas, splenic flexure, rectosigmoid junction. What are watershed areas? You must have to know these watershed areas. Watershed areas are actually the blind connections between two arteries or veins actually. So these are upper veins, right? For example, and these are lower veins, and they have blind connections in there, and this portion is watershed area. This portion is called watershed area. We'll talk about it detailed in our gastrointestinal anatomy, and it typically affects older adults. There is thumbprint sign on imaging due to mucosal edema or hemorrhage. Thumbprint sign. Okay. In ileus, what is ileus? Ileus is actually intestinal hypomotility without obstruction that will lead to constipation and decreased flatus, and distended tympanic abdomen with decreased bowel sounds can occur. Decreased bowel sounds, and it is associated with abdominal surgeries, opiates, hypokalemia, sepsis. There is no transition zone on imaging, right? So ileus is intestinal hypomotility without obstruction. The treatment is bowel rest, electrolyte correction, and cholinergic drugs which stimulate intestinal motility. These are the treatment. The another one here is necrotizing enterocolitis. It is seen in premature formula fade. Formula fade means mother is not feeding the child, right? It is formula fade with immature immune system. And the necrosis of intestinal mucosa can occur most commonly. Terminal ileum and proximal colon occurs, and which can lead to pneumatosis intestinalis. Pneumoperitoneum, that is air is trapped in peritoneal region, and also portal venous gas. Pneumatosis intestinalis. Let's see the figure in here. Okay, there are patches of air trapped inside intestine, which is called pneumatosis intestinalis. Okay, and in proctitis, there is the inflammation of rectal mucosa, usually associated with infection like Neisseria gonorrhea, chlamydia, campylobacter, Shigella, and then Salmonella, HSV, that is human syncytial virus, and cytomegalovirus. IBD is an inflammatory bowel disease and radiation. Patients report tenesmus, rectal bleeding, and rectal pain. Tenesmus is also present. Tenesmus is also the blood in stool, and proctoscopy reveals inflamed rectal mucosa, that is ulcers or vesicles in the case of HSP can be seen. Rectal swabs are used to detect other infectious etiology. So there is something called small bowel obstruction, right? What is small bowel obstruction? It is normal flow of intraluminal contents is interrupted, that will lead to fluid accumulation and intestinal dilatation. Proximal to blockage, and intestinal decompression distal to the blockage. This is small bowel obstruction, and it usually presents with abrupt onset of abdominal pain. This is abrupt onset of abdominal pain, nausea, vomiting, abdominal distension obviously, and there is compromised blood flow due to excessive dilatation or strangulation may lead to ischemia, necrosis, and perforation. These are the complications. Ischemia and necrosis, perforation, most commonly caused by intraperitoneal adhesions, that is fibrous band of scar tissue, tumors and hernias in rare cases. Meconium plug in newborns, that is meconium ileus, can occur in small bowel obstruction, and in upright abdominal x-rays, air fluid levels. This is air fluid levels. Here you can see clearly. These are air fluid levels in upright X-ray, upright abdominal X-ray, where the patient is standing. The management is gastrointestinal decompression, volume resuscitation, and bowel rest. So the another intestinal disease we have in here is small intestinal bacterial overgrowth. What actually happens in this case is that abnormal bacterial overgrowth in the small intestine is there, and this will lead to normally low bacterial colony count. The risk factors are altered pHs in achlorhydria. Achlorhydria is that there is no release of HCl in our gastric region. That can happen in PPI, that is PPI uses, which is gastric medicine for gastric ulcers like pantoprazole or omeprazole, esomeprazole, and anatomical variations like small bowel obstruction, Addison's, fistula, gastric bypass surgery, blind lobe, dysmotility as in gastroparesis, and also immunomediated, that is IgA deficiency, HIV, presence with bloating, which is abdominal fullness and flatulence, abdominal pain, chronic watery diarrhea, malabsorption of vitamin B12 in serious cases. Diagnosis is by carbohydrate breath test or a small bowel culture. That is how we do the diagnosis. Okay. Let's talk about colonic polyps. So what are colonic polyps actually? These are the growths of tissue within the colon. This can be benign, that is non-neoplastic, or can be potentially malignant, as in adenocarcinoma. We'll talk about that. We'll also talk about that. Okay, let's go into the colonic polyps, right? So did you finish your coffee? Because I haven't finished mine. I am constantly talking, right? So okay, there are growths of tissue within the colon like this. Pedunculated, sessile. Pedunculated has a stalk in there, but sessile doesn't have a stalk. STALK stalk like this. You can see in real figure, these are polyps. This is abnormal growth, right? They are grossly characterized as flat, sessile, or pedunculated on basis of protrusion into colonic lumen, and they are generally classified by histological type, which is generally non-neoplastic and potentially malignant. Okay, and in generally non-neoplastic portion, we have hematomatous polyps, hypermastic polyps, and inflammatory pseudopolyps, mucosal polyps, submucosal polyps, right? These have specific examples and names that we have to remember, like Peutz-Jeghers syndrome. So in hematomatous polyps, what actually happens is there are solitary lesions which do not have significant risk of transformation, and the most common associated in here is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, it has a Christmas tree like appearance, that is arborization in histology. You can remember like that. This is very high yield, and it has distorted architecture like Christmas tree. So, and also juvenile polyps. Here you can see in figure B, right? There, it also Peutz-Jeghers syndrome is also manifested as mucocutaneous inflammations. And in a hyperplastic polyp, what happens is this is the most common kind of polyp, and it is generally smaller and predominantly located in the rectosigmoid region. Hyperplastic polyps are predominantly located in rectosigmoid region. Occasionally, they may evolve into serrated polyps or more advanced lesions, and in inflammatory pseudopolyps due to mucosal erosion in inflammatory bowel disease. Mucosal polyps, they are small, usually less than 5 mm, and also they look similar to normal mucosa. Clinically insignificant. They are clinically insignificant, right? So in submucosal polyps, they may include lipomas, leiomyomas, fibromas, and other lesions. That is it. So in potential malignant diseases, we have adenomatous polyps and serrated polyps. This is very high yield. You have to remember both of these very detailed. And in adenomatous polyps, this is neoplastic. What actually happens is there is instability in chromosome, that is chromosomal instability pathway mutations in APC and KRAS mutation. There are variations of this, like tubular variation and then villus variation and tubulovillus variation. There are 3 variations of adenomatous polyps. Mutation is in APC, adenomatous polyposis coli, APC is that, and also KRAS mutation that can occur, that is chromosomal instability. So there are 3 variations. You have to remember tubular variation, villus variation, and then tubulovillus variation. And in tubular histology, it has less malignant potential, and in villus histology is villainous, that has more malignant potential, intermediate malignant potential. These are usually asymptomatic, may present with occult bleeding. You can see in here the figure 1. This is a tubular case. There are tubes, right? There are a lot of tubes in this case, but there are villas like this. This is one single villi, and this is another villi. These are another villi. This is villus, right? So that happens in adenomatous polyps. And in serrated polyps, these are also neoplastics, and they are categorized by CpG and methylated phenotype, SIMP. There are mutations in the SIMP. Cytosine base followed by guanine, linked by a phosphodiester bond is what happens. And defect may silence mismatch repair gene, that is MLH1 expression, and mutations lead to microsatellite instability and mutations in BRAF. Microsatellite instability and mutations in BRAF gene occur. And sawtooth appearance is the characteristic feature of serrated polyps. Sawtooth appearance, you have to remember this because this is also very high yield. Sawtooth appearance are present. Sawtooth means like this. Even by name, it justifies it, right? Serrated polyps. And in up to 20% of cases of sporadic CRC is present in here. Let's talk about polyposis syndromes. Polyposis syndrome, there are familial adenomatous polyposis. This is an autosomal dominant mutation of APC tumor suppressor gene on chromosome 5q21, q22. It has a 2-hit hypothesis. This hypothesis is also called Knudsen's hypothesis. You can note it down. KNUDSON. Knudsen's hypothesis. There are thousands of polyps arise starting after puberty, which is also pancolonic and always involves rectum. It has prophylactic colectomy or else progresses to 100% to the CRC. That is what it is. Another one here is Gardner syndrome. This is also high yield. Gardner syndrome in familial adenomatous polyposis plus osseous and soft tissue tumors are there. FAP, everything in FAP, that is familial adenomatous polyposis plus osseous and soft tissue tumor is Gardner syndrome, like osteomas of skull or mandible, congenital hypertrophy of retinal pigment epithelium, and also impacted supernumerary teeth that can occur in Gardner syndrome. And Torcott syndrome, this is also familial adenomatous polyposis or Lynch syndrome plus malignant CNS tumor is there. Lynch syndrome, we'll talk about that. So, Torcott syndrome is FAP plus or Lynch syndrome plus malignant CNS tumors, and Gardner syndrome is FAP plus osseous and soft tissue tumors. These both are very, very important things we have to remember, like Gardner syndrome and Torcott syndrome. We'll solve a clinical case in these two. And example, medulloblastoma and glioma. So Torcott is TOR1. This is mnemonics you can remember. And in Peutz-Jeghers syndrome, which we have talked earlier, autosomal dominant syndrome, it is also autosomal dominant, featuring numerous hematomatous polyps throughout GI tract along with hyperpigmented macules on mouth, lips, hands, genitalia. Hyperpigmented, these are macules, not papules, not blisters, these are macules. And also associated with increased risk of breast and GI cancers, example colorectal, and also stomach, small bowel, pancreatic. So in juvenile polyposis syndrome, what happens? This is autosomal dominant. All of the cases we have talked about earlier until now, these all are autosomal dominant cases. And it is typically present in syndrome, typically less than 5 years old, and featuring numerous hematomatous polyps in colon, stomach, small bowel. All of this has normal features, like similar features, right? So in MUTYH, which is a gene associated polyposis syndrome, it is autosomal recessive disorder. This is the only disorder in polyposis syndrome that is autosomal recessive, which is responsible for DNA repair. So associated with significantly increased risk of CRC, that is colorectal carcinoma, and polyps, that is adenomatous, may be hyperplastic or serrated, and serrated adenomas. They are also associated with duodenal adenomas and ovarian or bladder cancers. It can be associated for that. So in Lynch syndrome, this is also called hereditary non-polyposis colorectal cancer. This is Lynch syndrome. You must not afford to be confused in these two terms: Lynch syndrome and hereditary non-polyposis colorectal cancer, HNPCC. So this is autosomal dominant mutation of mismatched repair genes like MLH1 and MSH2 with subsequent microsatellite instability. So 80% is progress to CRC. Proximal colon is always involved, associated with endometrial, ovarian, and skin cancers. That is Merrill Lynch has CEOs. Okay. This is very high mnemonics. That is Merrill Lynch has CEOs. That is Lynch syndrome is associated with colon, that is proximal colon, endometrial cancer, and O for ovarian cancer, and S for skin cancer. So Merrill, or you can say any name in this. So Lynch had CEOs. You can remember just like that too. So let's talk about colorectal cancer, which is the last topic for our today's session. So your patience just paid off, right? So in colorectal cancer, let's talk about epidemiology. So in most patients are greater than 50 years and also have 25% have a family history. The risk factors include adenomatous and serrated polyps, familial cancer syndromes, IBD, tobacco use, diet of processed meat with low fiber. That can occur colorectal cancer. Presentation is, you have to remember this priorities or these incidence rates. That is, rectus sigmoid is maximum and then ascending, then descending colons. These most are asymptomatic. Right-sided, that is sickle and ascending, are associated with occult bleeding, whereas left-sided are associated with hematochezia and obstruction. That is narrower lumen that will decrease the stool caliber. Right? So in ascending cases, there is exophytic mass, iron deficiency edema, anemia, and weight loss. And in descending cases, there are infiltrating mass. So in ascending cases, these are exophytic mass, and in descending cases, these are infiltrated mass, like this. Right? And they also cause partial obstruction, colicky pain, and hematochezia. And they can present with S. bovis, that is galolyticus, and bacteremia, endocarditis, or as an episode of diverticulitis. The diagnosis we will do by iron deficiency anemia in males, and also postmenopausal females raises suspicion. Okay. And in screening, the average risk is that screen at age 45 with colonoscopy, polyps seen in A. In these cases, there are polyps. Alternatives include flexible sigmoidoscopy, fecal occult blood testing FOBT, and fecal immunochemical testing FIT, FIT, and FIT fecal DNA and CT colonography. These are the methods of screening. And patients with a first degree relative who has colon cancer screen at age 40 with colonoscopy or 10 years prior to the relative's presentation. Okay. Patients with IBD screen 8 years after onset. Okay. So apple core lesion on a barrier minima X-ray. You can see like apple core region, right? Apple core region. It looks like the apple that is eaten right here. Okay. So in barrier minima X-ray it is seen in. And CEA tumor marker, it is very good for monitoring reoccurrence, should not be used for screening. So what is the molecular pathogenesis of colorectal cancer? There is adenoma carcinoma sequence. You have to remember these mutation genes. You have to remember these genes, right? So chromosomal instability pathway, mutations in APC cause FAP, and most sporadic cases of CRC, that is commonly left-sided by adenoma carcinoma sequence. Most commonly left-sided via adenoma carcinoma sequence, right? You have to remember this adenoma carcinoma sequence. And also microsatellite instability pathway is there. This is a very important reason for this pathophysiology, where there is mutations or methylation of mismatch repair gene, that is MLH1. You can remember from MMMMM, that is microsatellite instability pathway, that is M for microsatellite instability pathway, which is due to mutations or methylation of mismatch repair genes, that is for example MLH1 or MSS2. So that is how we remember MMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMMmmmm. So it causes Lynch syndrome and some sporadic CRC, commonly right-sided by a serrated polyp pathway, and overexpression of COX2A has been linked to CRC. NSAIDs may be chemopreventive. Okay, NSAIDs may be chemopreventive. Here is the flow chart in here. Adenoma, carcinoma sequence. Chromosomal instability pathway, always kill polyps. A for APC, right? So normal colon, loss of APC gene is there, so decrease in intracellular addition or increase in proliferation occurs, that is colon is at risk. At risk colon, there is KRAS mutation again, so K for KRAS mutation, that will lead to unregulated intracellular signaling, and that will form an adenoma like this. And in that adenoma, there is P for, there are double P in polyps, right? So loss of tumor suppressor genes, that is TP53 and DCC genes, that will lead to increase in tumorigenesis causing carcinoma. So always kill polyps. This is in sequential manner in the presence of time, right? So like in the presence of complications that is arising. So A for APC gene. If the mutation in APC gene happens, then you have to prevent, if you can, the next mutation, that is colon at risk, which is due to KRAS mutations. Always A for APC mutation, K for KRAS mutation, and PP for suppressor gene mutation, TP53 mutations, right? That is how we conclude our session. This is our second session, and we will talk about cirrhosis and portal hypertension in our next class, our next session. Stay with me. Thank you for staying with me if you are still here, and subscribe if you haven't already. So let's get connected, let's build a community, and let's grow. Thank you.